Welcome everyone. This is Dr. Jaitley, your cardiologist from New York. Welcome on Muni Meter Health, your video channel on several social platforms. We advance medical education to our medical fraternity groups and, of course, patient education to our general masses in order to improve the clinical outcomes, because a combination of the two definitely result into highest clinical outcomes that one can expect. So again, this is purely an educational channel. It's not a treatment advice channel, and it's definitely not a substitute to a syllabus, but maybe a supplement to the syllabus to my medical students. So just make a note of that. Today we're going to be discussing what is PTCA and what are stents, and obviously what are PCIs, which is percutaneous coronary interventions. So these were the terms which were coined, I guess, over the period of time. Now, the earliest PTCAs that happened were by Dr. Grunzig in 1976 to 78, very landmark studies where a balloon was passed on a catheter. And as you see, there are atherosclerotic plaques here. These are all the plaques within the coronaries here. These are your coronaries, if you will. And so the plaques, as they become more and more stenotic, like normally the cutoff is about 65 to 70% of that luminal stenosis, if it exists, then obviously that becomes a significant coronary artery disease. And at that point, the plaque needs to be either removed, or you could actually suppress it against the wall. So the invention of passing a catheter and then inflating a balloon, this is the balloon right here, and that balloon gets inflated, and that will push this plaque, the same plaque here, against the wall. So the endothelium now has a compressed plaque, if you will, and this catheter was pulled out. So that happened in 1976 to 78, more or less, and continued in mid-80s. And the problems were obviously still that, again, this was just an advent of angioplasties at that point, so the abrupt closure was a huge problem. Late restenosis occurred in many of these individuals, and the artery started to remodel because of various changes of the flow and the shear flows that altered after the balloon was removed. And then there was an intimal hyperplasia, which was a response from a foreign body that was initially introduced and later on removed. And the restenosis rate was 30 to 35%, despite aspirin, which was already around, the wonder drug at that point, and still is. So the aspirin was still around at that point. There were no clopidogrel or 2B3A inhibitors at that point. Then in late 90s, a term percutaneous coronary intervention was coined, and that was primarily because a stent was the philosophy that was being employed at that point. Instead of taking the balloon out, the attempt was to see if you could actually leave a stent back in. And a stent implied that the catheter would be passed in like this through the artery. And then there would be a stent which will be deployed here, and we'll show it in a different color here, if you will. And that stent would actually now sit against this plaque which was pushed against the wall, and we'll show it as it was like a metallic mesh, if you will, and almost like a ballpoint spring. If you remember the old ballpoint pens, today we have different sketch pens now. Now I'm using a virtual online pen here. So this is what it looked like. So initially, what the process was to put the balloon, inflate, push the plaques out into the wall, and then take the catheter out, put another catheter within the artery, at this time with a stent deployed inside at the place where the balloon inflation occurred. So this stent was left, and the catheter was again pulled out. So now the bare metallic stent was still having problems, where there were still issues of in-stent restenosis. However, the abrupt closure, which normally occurred with these PTCAs, the abrupt closure that was occurring here, that was reduced markedly. So the early failure, if you will, on the PCI or PTCA procedures, that was dramatically reduced. But late in-stent restenosis still remained a problem, and that was because of the new intimal proliferation that still continued to occur, because obviously now you left a foreign body inside the artery. Now, in early 2000s, so the progression of the invention continued, and early 2000s, it was drug-eluting stents that actually started to be deployed, and that was mainly to see if somehow the polymerized the polymer drug inside the stent will continue to wash the thrombus that was forming after a year or close to a year. So the whole idea is wanting to see if these drug-eluting stents, we call them DES, they would start washing away the thrombus as it was forming. So this way one could actually keep these stents from clogging, because the in-stent restenosis was still high with the BMS, almost 10 to 15%, as you see here. So now with the drug-eluting stents, it was dropping to less than 10%, more or less. And the two stents, the first generation DES, were sacrolimus, and the other one was paclitaxel. Sacrolimus became known as Zyfer later on, and the paclitaxel became known as the Taxus DES. So again, these were anti-proliferative drugs. They were also biocompatible, obviously, and they were biocompatible polymers, and they were on a metallic platform, just like a metallic stent here originally that was placed in. Now you have a drug-eluting stent, which was helping. However, the late thrombosis issue was still not addressed, and therefore the second generation DES, or drug-eluting stents, came around in mid 2000s, 2005 to 2010. They were biocompatible and they were bioresorbable polymers. So now we wanted to see if there was a polymer that could be actually resorbed rather than just sit there. So basically they were resorbed within the intima and within the artery itself, and therefore over a period of time they'll just continue to make sure that the thrombus would not form, and they would be only delivering the drug locally into these atherosclerotic plaques, more or less somewhere here. So the whole idea of second generation DES was to come up with these two drugs called Zotarolimus and we call them everolimus. One of them became known as Endeavor, and the other one is known as Ziens 5. So these two are the prototypes right now, which are the two second generation DES, and they have very good results so far, comparable with the first generation DES as well. So in a nutshell, you've learned how the stents evolved. Again, atherosclerotic plaque here. We have a balloon which goes in, presses the plaques against the wall, and then a catheter is changed, and a different catheter brings the undeployed stent within it, and then right by the area where the balloon was originally compressing these atherosclerotic plaques against the wall, that's where the stent is deployed. The word is called deployed because it's active, and it's like an umbrella, and it just stays there, and then the catheter is pulled out, so it's now nicely deployed within the area. So in a nutshell, you heard the history of the PDCA, the stents, and the PCI. Hope this was helpful. So stay tuned for more exciting stuff coming on Munimeter Health, and thank you for watching, and stay healthy and stay with Munimeter Health. Thank you so much.